Hello, my name is Tom Fleming and I'm one of the orthopaedic registrars working in Gloucestershire Hospitals NHS Foundation Trust. Thank you for having me to speak today. I'd like to discuss the influence of CT scanning in the surgical planning of tibial plateau fractures during the COVID-19 pandemic. The problem. COVID-19 has put pressure on the NHS as a whole, and we were asked as a department to justify whether cross-sectional imaging was required as part of our operative plan. There was a feeling in our department as to whether we had a CT reflex, see a tibial plateau, get a CT scan. We looked at the literature and asked to what extent does a CT actually change the operative plan in comparison with an X-ray, and we couldn't find much on this. The classification has evolved from Schatzker, which we all know based on the AP X-ray, to allow popularising the column classification, which is three-dimensional based on the CT scan. Chang further modified this in 2014, including the posterolateral quadrant. We looked at 50 consecutive cases with tibial plateau fractures operated on in our trust that had preoperative CT scans. Exclusion criteria were any patients less than 16 years old, those with periprosthetic fractures or pathological fractures. The data was then analysed by 4 consultant trauma and orthopaedic surgeons with a mean 29 years experience post-medical school. They then derived an operative plan. The operative plan included looking at the column classification and the orientation of the fractures, the incisions that they would use to fix this injury, the position of the patient, and then ultimately where they were going to put their plates. We then asked the question, would a CT scan be indicated based on the operative plan from these X-rays? Round 2 was done at a 1-month interval in a randomised order with the addition of the CT scan and the same parameters examined. At a further 1-month interval, a random selection of 25 cases was used to look at intra-observer reliability. The results. There were 24 males and 26 females with a mean age of 50. The most common number of days to wait for a CT scan was 1, with the average being 2. The delay to surgery was 6 days, and the spread is seen here on this graph, and 96% of patients had an open reduction and internal fixation. A tibial plateau disruption score was derived for each quadrant, with 0 being no fracture, 1 being a split, 2 a split depression, and 3 a depression. As predicted, a CT scan picked up a higher grade of injury with a mean of 2.77 on X-ray to 3.17 on CT scan, and this was statistically significant looking at ANOVA score. The fracture morphology altered in 34% of cases on the CT round compared to the X-ray round. Interestingly, no additional apices or fracture lines were identified in quadrants, they just altered in where they were on the CT scan compared to the X-ray round. This did change the approach in 28.5% of cases, and it did change the plate location in 27.4% of cases. All surgeons could only agree that 22% of cases did not need a CT scan before theatre. We can therefore conclude that CT scan does affect the approach, the setup and the classification, and justifiably can be requested as part of the routine preoperative workup in these injuries. Thank you for listening, and I'd like to invite any questions.